Good afternoon, and thank you for joining us for this webinar. I welcome you on behalf of the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, and the Director, Mr. Derek Springer. My name is Vivian Rockham, Senior Project Officer of the 10th European Development Fund Project at the PANCAP Coordinating Unit. This is our first of 4 webinars for parliamentarians. The objective of these webinar sessions is to share current evidence, implementation experiences, and best practices in creating an enabling legislative environment for the HIV response. Just to remind you, PANCAP has been involved in discussions with parliamentarians through a series of consultations since 2013, which informed the development of the PANCAP Justice for All program. Just to give a brief background, the Justice for All program was introduced as a regional response to the UN High-Level Political Declaration, June 2011, designed to reduce AIDS-related stigma and discrimination. The Justice for All roadmap revolves around 5 principles. The first, enhancing family life and focusing on those in need. Second, increasing access to treatment and affordable medicines. Third, reducing gender inequality, including violence against women, girls, and adolescents. Fourth, promoting prevention with special reference to sexual and reproductive health and rights, including age-appropriate sexual education. And the fifth, implementing legislative reforms for modifying AIDS-related stigma and discrimination. For those of you who may want additional information on the PANCAP Justice for All program, please visit the PANCAP website. Just a few housekeeping notes before we proceed. Your mics are muted. If you have any questions during the presentations, I encourage that you type these in. We will address the questions during the question and answer segment after the presentations. You will receive a poll during the presentation. The poll will be up for 1 minute. I encourage you to participate. I will provide insights that will allow our presenters to, on the spot, tailor their presentations to share their experiences based on our opinions. This webinar will be recorded and shared on the PANCAP website. We will notify you when this is shared. Once again, welcome. The topic for today's webinar is making the case against the criminalization of willful transmission of HIV. We have 3 main objectives. The first is to share evidence on the negative impact of the criminalization of HIV on the response. Second, to understand the Guyana process in rejecting a parliamentary motion to criminalize HIV. And the third, to share other Caribbean experiences in rejecting the criminalization of HIV. It is my pleasure to introduce you to our first speaker, Dr. Frank Anthony. Dr. Anthony is a consultant contracted by PANCAP to provide technical assistance to parliamentarians. Dr. Anthony is a medical doctor, public health practitioner, and a member of parliament in Guyana for more than 12 years. He has served on various committees in the Parliament of Guyana and is also a serving member of the Parliamentary Management Committee and Constitution Reform Committee. I now hand you over to Dr. Anthony.
Thank you very much, Vivian. Welcome everyone to this PANCAP webinar on making the case against the criminalization of the non-disclosure, exposure, and willful transmission of HIV. A few weeks ago, PANCAP, through the 10th EDF, held a sensitization forum on the role of parliamentarians in ending AIDS, the AIDS epidemic in Jamaica. During the discussion, we learned that Jamaica was considering introducing laws that may lead to the criminalization of HIV non-disclosure, exposure, and transmission. At the meeting, the discussion was quite interactive, and because of the limited time available at the forum, it was decided that we should continue this discussion using the webinar format. This particular webinar would consist of me making a general presentation, which would be followed by Dr. Ramsammy's as former Minister of Health in Guyana, who had first-hand experience in dealing with an opposition motion calling for the criminalization of HIV transmission. He would share the Guyana experience, and after Dr. Ramsammy's presentation, there'll be an interactive question and answer period. As you all would know, that in the 1980s, the world became aware of AIDS. Not much was known at the time, excepting that there wasn't a cure. And once you contracted it, it was like a death sentence. This generated quite a lot of fear. And reacting to that fear, a lot of countries decided that they have to implement special legislation to prosecute persons who transmit or who did not disclose. Among the countries that introduced this legislation, the United States was the first country to do so, and this happened in 1987. And after following the example of the United States of America, you had 68 other countries then followed suit. And they implemented special laws that allow for the criminalization of non-disclosure, exposure, and transmission. 33 other countries did not enact special legislation, but have used their existing laws to prosecute HIV-positive persons. Most of the cases of criminal prosecution have been framed as deliberate or intentional HIV transmission, which in fact, the majority have evolved either to say that there was an intention to transmit. The use of criminal law in this way became problematic. And UNAIDS and many other agencies express various concerns. The top three concerns were, one, that these laws often do not take into consideration the latest scientific and medical knowledge as it relates to HIV. The second concern was that they disregarded the principles of criminal law. And the third concern was that the sentence imposed were disproportionately harsh. In case of where they disregarded generally applicable criminal law, what we found was that a lot of the principles that are used in other cases to have a stronger burden of proof in terms of intention, causality, proportionality, to have defense and proof. In many instances, when people are prosecuted, a lot of these things are not in place. And so they have been, in many instances, a miscarriage of justice. These laws, in its application, have actually, instead of assisting the public health efforts in curbing the epidemic, have actually undermined the efforts of public health professionals. How do we apply the law? UNAIDS actually, in one of its recent publications, have advised governments that rather than spend a lot of time trying to craft laws, that one of the things that they should be doing is to expand evidence and right-based approaches to prevention, treatment, and care. And that if you have existing laws, that you should really limit the application of those laws to very rare instances when these cases are really blameworthy. Since 2008, UNAIDS have argued that argue that there must be limited application of the law to cases of intentional transmission. That is, where the person knows their HIV positive status and acts with intention to transmit and does in fact transmit. So it's not only the intention to transmit, but transmission has actually occurred. In the UNAIDS guidance document of 2013, which is aptly named Ending Overtly the Broad Criminalization of HIV, Non-Disclosure, Exposure, and Transmission, critical scientific, medical, and legal considerations, they have pointed out that many of the laws are pretty much outdated and does not take into consideration what is the science that is currently available in assessing harm, in assessing risk, and in assessing culpability. So we'll focus on a little bit on these three areas. How do we assess harm? How do we assess risk? And how do we assess culpability? In terms of assessment of harm, UNAIDS, one of the things that they have said is that if there's no transmission, then if someone did not disclose their status to their partner, then non-disclosure should not be criminalized. Similarly, if someone has exposed another person, someone who is HIV positive has exposed a non-HIV positive person, and there was no transmission, then that exposure should not be criminalized. In fact, UNAIDS has pointed out that the law to prosecute persons should be used very sparingly, because what was considered as harm 30 years ago is no longer valid. As you would know, with modern science, we have ARVs, and with ARVs, HIV now is a chronic treatable condition. And so in the early days of the epidemic, things like the categorization of charges for persons who were positive and transmit to other persons, in the law, you would see things like charging people for murder, for attempted murder, for manslaughter. These types of charges must be used very guardedly, if at all, because the advances that we have in science and technology has now shown that you can have very little harm. In terms of factors that influence transmission, there are factors that can increase transmission, and there are factors that can decrease transmission. And one of the things that we all know, and this has been with all the public health programs, is that if you use condoms correctly, then HIV transmission does not occur. And this has been proven by a number of studies that were done across the world. The second thing, so this decreases the chances of transmission. The second thing is that viral load, that is, if you have a very low viral load, meaning that it's undetectable, then it's almost impossible for you to transmit the infection to an HIV negative person. Viral load becomes undetectable if persons are treated with ARVs. The other thing relating to treatment is that persons who are at very high risk, one of the things that is being recommended now is that we should have pre-exposure prophylaxis. And this significantly reduces the possibility of HIV acquisition. And even in some cases, when you do have exposure, persons can use post-exposure prophylaxis. Other studies have shown that medical male circumcision in certain circumstances decreases the possibility of HIV transmission from woman to man. There are also other risk reduction practices that, if used, would decrease transmission. In the case of an increase in transmission, it has been shown that co-infections with sexually transmitted diseases, and especially if these diseases, if they're ulcers, that this can increase transmission. So if you treat these diseases, the chances are that you'll be able to decrease transmission. Now, when we talk of viral load, one of the things that we see after the infection is that a person would have a very high viral load, and then that decreases. And the attack on the immune system, initially the body is able to react to it, but if left untreated, then the body itself would eventually succumb and the immune system would not work. When we spoke about being undetectable, viral load being undetectable, it means that these persons, if placed on treatment very early, the chances of viral load increasing decreases significantly. And this is something that is now recommended. In fact, the new thing that is being touted is that if viral load is undetectable, then it's untransmittable. And there are many, many studies that have borne this out. Some examples are the HPTN 052 study, the partner study, and opposite attract studies. All of this has shown that if the HIV positive partner has an undetectable viral load, then it's almost impossible for them to be able to transmit this virus. The Center for Disease Control now describes that the estimated possibility of HIV transmission from an HIV positive person with an undetectable viral load, that effectively there's no risk. This has also been validated by a number of other public health agencies and around the world. So this here is science that has been tested and shown that once people are on treatment, the possibility and viral loads are undetectable, the possibility of transmission is almost zero. Again, just speaking of pre-exposure prophylaxis, a lot of the studies have shown that PrEP is up to 95% effective. In fact, most of the studies have pegged it at 95%, but other studies have shown that it is even higher than 95%. But the 95% is really a conservative estimate. And when PrEP is used with other prevention methods, then this is even further decreased. The same thing with post-exposure prophylaxis. If you're treated within the 72 hours, and the earlier you're treated, the better the results have been, and you continue that treatment for 28 days. Once you have good adherence, the likelihood of that person converting is rather small. And with newer regimes of treatment, some of the studies have shown that post-exposure prophylaxis is even close to 100% effective. So it brings us then, how do we assess risk? One of the traditional ways of assessing risk is that we want to ensure, and most of the criminal law has pointed out, that the risk must be significant. So even if in some countries what they did was, even if there was no transmission, they went after people because they said these persons posed a significant risk in the transmission of HIV. So the HIV negative person did not get the infection, but there are laws that would state that if there's a significant risk, that people can be prosecuted. As was pointed out earlier, with the different methods of prevention, such as condom use, PrEP, and low viral loads, that the risk of transmission is extremely low, if at all. And therefore, to simply prosecute people based on some notion of a significant risk is not in keeping with current science. There was also early in the epidemic when people were prosecuted for kissing an HIV positive person, kissing an HIV negative person. When there was discovery of this, people were prosecuted for kissing. In some cases, people were prosecuted for biting, for scratching, for throwing fluids that somehow maybe might have HIV in it. All of these methods have been, or all of these things have been tested scientifically by a number of studies. And they have all proved that you cannot transmit HIV by kissing, biting, scratching, and so forth. Yet, for the countries that have HIV-specific laws, many of these provisions are still in place. You can see here for a single act, the different types of sexual act and the risk that they pose. And you can see how small that risk is. And these have been calculated from various studies. So a woman who engages in unprotected vaginal sex with an untreated HIV positive man, the risk of HIV infection is calculated to be at 0.08. That is 1 in 1,250 interactions, or per act. So this is the per act risk. And similarly, you can see for other types of sexual act. So from this table, which has been scientifically put together, you can actually see that risk, as we originally conceived it, is fairly low. And therefore, this should really cause us to examine what we might consider to be significant risk. As I said before, casual contact, you might be amazed to see that in some of the laws, they actually have put into the laws things relating to casual contact. And of course, the science has now shown that if you share a chair or a toilet seat with someone who is HIV positive, that you cannot contract HIV by these methods. But yet these laws are still in place, or these provisions are still in place, quite inconsistent with the science that we have. And I already spoke about biting and spitting. These things really, you cannot transmit HIV. Assessment of culpability. An assessment of culpability must show that there's a clear intent to transmit. Person must not only have knowledge of their HIV positive status, but they must take deliberate action that pose a significant risk for transmission. And more importantly, there must also be proof that the action is done for the purpose of infecting someone else. The United Nations have come up with recommendations. And one of the things they said is that where there's no significant risk of HIV transmission, then persons must not be criminally prosecuted. Where the person did not know that he or she was HIV positive, they must not be prosecuted. Where the person did not understand how HIV is transmitted, that person should not be prosecuted. Where the person disclosed his or her status to the person at risk, then that person should not be prosecuted. And again, where the person did not disclose his or her HIV positive status because of violence or serious negative consequences, that person must not be prosecuted. Where the person took reasonable measures to reduce the risk of HIV transmission, such as practicing safer sex, the correct use of condoms, and so forth, then that person should not be prosecuted. Where the person previously agreed on a level of mutually acceptable risk, then the HIV positive person must not be prosecuted. So in conclusion, what we have to look at is that countries may need to seriously think whether the implementation of laws to criminalize HIV non-disclosure, exposure, and transmission is in the best, in the public's interest, and whether that is the best public health measure. There has been more than 30 years of evidence that says that these laws do not help the public health effort. The science of the disease has changed tremendously from when we started in the early 1980s to now, and all the recommendations from the various agencies have recommended that we use science in making our decision. The three main factors used to prosecute people who are HIV positive, that is, harm caused by HIV, has been significantly reduced. Risk has also, or what we might term in a lot of the laws as significant risk, that too has been significantly reduced, as I have pointed out, by the various sex acts and the measures that one can take in terms of prevention. In fact, for most of these things, it ranges between low possibility to no possibility. And therefore, it is not about significant risk. It is, even lower than that. And of course, the third one, the burden of proof. You must establish that there was intention or intent to harm. And if we cannot prove this, then we should not be prosecuting people. So these would be some of the points that I would like to raise, and I'm sure you will have questions when we open the question and answer period. Thank you very much.
Thank you very much, Dr. Anthony. Thank you very much for this very insightful presentation. Thank you for providing context under which these laws were formed. Also outlining the factors influencing transmission and the likelihood of transmission of HIV. And not forgetting the scientific evidence which suggests that criminalization of HIV transmission is generally an unjust and ineffective public policy. I again encourage everyone to type their questions in. We will address them after the presentations. It is now my pleasure to introduce to you our second presenter, Dr. Lesley Ramsammy. Dr. Ramsammy is a former Minister of Health and Minister of Agriculture in Guyana. He also served as a Member of Parliament in Guyana for more than 20 years. At the regional level, Dr. Ramsammy served as Chairman of the Caribbean Communities Council for Human and Social Development, COSAD. He also was the chair of the Caucus of CARICOM Ministers responsible for health. and chairman of the executive board of the Caribbean Public Health Agency, CARFA. At the international level, Dr. Ramsammy served as the president of the World Health Assembly and the PAHO Directing Council. He was also a representative for Latin America and the Caribbean on the board of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. I now hand you over to Dr. Ramsammy.
Thank you very much, Vivian, Frank, and colleagues throughout the Caribbean. It's a real pleasure to be part of the PANCAP family for this very important webinar. Dr. Anthony has outlined very clearly some of the science we know. Even in 2010, when Guyana was in the midst of confronting a movement for HIV criminalization, there was already strong evidence that embarking on that pathway was wrong. Today, 20 years later, or 10 years later, there is unequivocal, there is compelling evidence that the pathway towards HIV criminalization is wrong. Colleagues all, at the time I became minister, in Guyana and in the Caribbean and in other jurisdictions, there were several proposals circulating to criminalize one or more aspects of HIV. One of those was to charge people living with HIV for knowingly transmitting HIV to another person. There were proposals for public disclosure of HIV status in the same manner as sex offenders in some jurisdiction are publicized, and in the same manner that Canada published the pictures of people living with HIV in newspapers. There were proposals for using HIV status in sentencing guidelines. There were also proposals to prohibit people from entering a country, and unfortunately, a couple of Caribbean countries at the time, and I think still, have those laws in the books. There were proposals to prohibit people living with HIV from certain professions, like being a dentist or being a surgeon or being a nurse. And in fact, as far as I know, in Guyana, for example, people applying to join the police force or the army have to have an HIV test. Their eligibility was determined by their HIV status. There were proposals to follow Cuba and introduce quarantine laws in our various countries. Now, at the time, in the 1990s, just before I became minister, and when I was minister throughout the first decade of the 21st century, these proposals they received strong support from international groups, particularly from the American right religious groups. And so there were persons like Philip Lee and other US activists, religious activists, who were providing financial support and advocacy for these laws in Guyana and in the Caribbean. In Guyana's case, the movement got major catalyst from our own effort to introduce amendments to the Constitution to prevent discrimination based on sexual orientation. Whilst these groups came in mainly for an anti-LGBT agenda, and particularly the UN effort to push our countries to remove punitive laws on, say, buggery, for example, they branched out into advocating for American-style HIV criminalization. in 2010, the movement for criminalization in Guyana took a major step forward when a MP from a small opposition political party introduced a motion in Parliament to criminalize HIV. There were four resolve clauses, the impact of which was to um, to have public disclosure of HIV status, um, and secondly, for prosecutors to be able to charge people for transmitting HIV, and charge them with aggravated injury, with attempted murder, with murder in some instances. Uh, the the motivation for this MP and for those groups that were pushing HIV criminalization law in Guyana were not different from the motivation, say, in the US or in Canada or in Europe or in other Caribbean countries or African and Asian countries. Basically, there were 6 platforms on which they worked. One was the anecdotal stories of people living with HIV, deliberately luring women for consensual sexual encounters with a specific purpose of spreading HIV. Whilst there have been some documented cases around the world, there remain a small subset. There was a belief in this group that persons living with HIV engaged in certain violent acts, including rapes with women. There was the belief that the HIV population were people with unacceptable behavior. They deemed it depraved behavior. This includes same-sex relations, sex work, and drug use. A fourth platform on which they operated was that if these laws were good enough for the developed countries such as America and Canada, then it had to be good for Guyana. It had to be good for any developing country. They also worked on the misguided representation that UN AIDS and other UN bodies recommended such laws. And finally, they believed that these laws were not just punitive, they were not just retributive, but that these laws served as a strong deterrent. So this is where they were working from. The It is important for us as parliamentarians and for the general population to know that at the time these proposals were circulating in Guyana and the Caribbean, we had all recognized that stigma and discrimination play significant roles in transmission, in the progression of HIV/AIDS in our various countries, and that PANCAP was leading the regional effort to combat stigma and discrimination. In fact, in 2010, when the motion was introduced in Guyana's parliament for criminalization, PANCAP had a model anti-stigma, anti-discrimination legislation that they had intended the various countries to adapt and enact. Guyana, to its credit, had begun consultation before the PANCAP model legislation in 2004. And by 2006, we in fact had a draft legislation that made its way to cabinet. We got distracted in trying to combat the advocacy for criminalization of HIV, and unfortunately, it never made it on the parliamentary agenda. I find that it is worrisome, and to my great chagrin, that the PANCAP anti-stigma, anti-discrimination legislation will remain on the shelf. And as far as I know, and I hope that I am wrong, that not a single CARICOM country has adopted these proposals into national legislation. So this is kind of the background in which we had this motion in Parliament. The motion did not have serious support in Parliament. In fact, as far as I know, other than 3 or 4 of the MPs out of the 65, there was overwhelming rejection of the motion. And, and indeed, many of my colleagues thought that the best way to deal with it would have been to just simply dismiss it and move on. I thought that would have been a mistake. I thought that we should use it to engage those persons advocating for criminalization. I thought it was an opportunity for us to engage different players with different views. And educating and making them more aware of what we had in place to fight HIV. And to make our country safe against HIV. One of their major platforms was the HIV status disclosure. I had consultations with the advocates and with various groups in Guyana to update them on the various laws we already had in place to deal with disclosure, because I conceded that there was mitigating circumstances where disclosure may be necessary. Guyana had a national AIDS policy that was revised several times. Guyana had a code of conduct and standards for practice for physicians. We had clinical guidelines for HIV diagnosis and treatment, guidelines for voluntary counseling and testing, for prevention of mother-to-child transmission, HIV transmission. And there was a Sexual Offences Act in 2010, all that provided for disclosure under certain mitigating circumstances, so that one plank of the motion was already addressed in Guyana through practice and through laws. In terms of the willful transmission, I conceded, as did many of us, conceded that there is justification for criminal prosecution where a person willfully, purposely, or maliciously transmit HIV to another person. But our contention, and as Dr. Anthony showed in his open presentation, even at that time, there were compelling evidence that existing criminal laws are adequate to prosecute these cases. In fact, in the rare cases where cases were prosecuted, reviews have shown in the last decade that specific HIV laws are not any more effective than prosecution under existing laws, and that in fact specific HIV laws used to prosecute these cases create further disadvantages and injustices. And so instead of dismissing the motion in Parliament, what we agreed to, and the President Barjadeo at the time encouraged us to do, was to amend the motion, removing the 4 resolve clauses and replacing it with a resolve clause that called for continued dialogue, for setting up a special select committee and engaging at the national level advocates for and against, bringing in international experts and local experts, providing an avenue for the voices of people from different walks of life, from different advocacy positions, to have their voices heard, rather than just simply dismissing them and don't give consideration to their concerns. Parliament, therefore, based on this amended motion, established a special select committee. I, in fact, chair that special select committee, and I believe, and I know Dr. Frank Anthony was part of that special select committee. Um, we met many times. We invited the public to make oral uh, and uh, and and written presentation. We invited international experts and international groups. So UN AIDS made a presentation. UNFPA, UNICEF, UNDP made presentation. Um, Groups representing people living with HIV in Guyana and in the Caribbean made representation. SASOD, the group representing LGBT in Guyana, made presentation. Various church groups, the Guyana Human Rights Association made presentation. So we provided a forum for people to have their voice heard, to have their concerns addressed. At the end, the Special Select Committee made the following finding: that there was no need for an HIV-specific criminal law in Guyana, that criminalization is counterproductive, and the evidence was available then, and today that evidence is even more compelling, that criminal laws dealing with HIV transmission are often unfairly and selectively enforced. Today, the evidence shows that these criminal laws um, embellish and add to injustice. And finally, that criminalization places greater responsibility on people living with HIV/AIDS, the sole responsibility on people living with HIV/AIDS. The Special Select Committee recommended that we must continue our comprehensive effort to provide education and awareness. We must continue with our for testing and treatment to reach everyone. That whatever we do, we must comply with international human rights convention, and that we should enact legislation to address stigma and discrimination relating to HIV, particularly when it comes to protection of women and girls and vulnerable groups like LGBT and other groups. Um, the um, and so it was an experience that uh, steer Guyana away from criminalization and focus more on an effort on education and awareness, dealing with stigma and discrimination, for testing to be accessible, completely accessible, and for treatment to reach everyone that need them. We learned a number of things, and colleagues, I would uh, recommend that we neglect outside stakeholders at great peril. They are well funded and they are buttressed and buffered by an ideological and a religious cover that find solid support, even if it's in small bases in our various countries. In Guyana, we still have a persisting movement for criminalization. Um, I think that education and awareness is an unfinished business. But in educating people and making people more aware, we must also look for compromise and middle ground. For those who um, advocate proposals that sometimes are counter to good public health practices, it is better that we work with them to get middle ground. We must avoid totally an us versus them approach in confronting HIV criminalization advocacy. The parliament and parliamentary debate and having special select committee inviting the public to make presentation is a powerful, powerful tool. People want their voices heard. People want to feel that their concerns are not being dismissed and are being heard. And I believe that after that special select committee engagement with the public, the movement for criminalization, whilst it did not die completely, was greatly diminished. And I believe there is an absolute need for anti-stigma, anti-discrimination laws even today. And so I would urge that the PANCAP model legislation, even if it needs some revising, should be considered in the various countries. And so let me make these closing remarks. despite evidence against HIV criminalization, and Dr. Anthony did a good job presenting some of that evidence, there is still a worrying measure of public support that persists. I believe that HIV criminalization laws discourage disclosure of HIV status to potential partners and parliamentarians. There is a trove of studies that are now available to show that HIV laws discourage disclosure. And when it does so, people living with HIV go underground, where prosecutors cannot reach them. But not only prosecutors cannot reach them, neither can testing and treatment services. The HIV criminalization laws, colleagues, are totally discriminatory, entrenching patterns of disadvantage. In every single jurisdiction where these laws have been implemented, they have created more injustices. In all of these jurisdictions, our saliva, our blood, our semen have become lethal weapons, sometimes greater than assault weapons such as AK-47. And people, women, girls, LGBT people, people of different races, they are at a disadvantage in many of these jurisdictions. The most powerful tool against HIV transmission is still testing and treatment. HIV criminalization laws open the doors for other criminalization. What will we do when somebody wants to charge us for HPV transmission because it causes certain cancers like like cervical cancer? And finally, I will appeal and I will urge that HIV criminalization is bad, terrible public health policy. So I find it inconceivable. I find it very worrisome that so many decades after, there might still be some Caribbean parliamentarians contemplating criminalizing HIV. Our remit as representatives must be to provide rights, to respect those rights, to protect those rights, to fulfill rights for all citizens. Any attempt to criminalize HIV would be an abrogation of this remit. Because the willful transmission of HIV is a genuine concern, it is hard, I know, to say no to criminalization, but rejecting HIV criminalization is unequivocally the right thing to do. Thank you all. Thank you very much.
Thank you very much, Dr. Ramsammy, for your presentation. Thank you for helping us understand the Guyana process in rejecting the parliamentary motion to criminalize HIV, the motivation and the implications of such a motion on other policies and laws, and ultimately the HIV prevention and treatment agenda, and also the critical approach and work and recommendations of the Joint Select Committee in Guyana. Just to address two comments that you made during your presentation, the first being in relation to the PANCAP Model Anti-Discrimination Bill. Unfortunately, you are correct. No member state has adopted the PANCAP Model Anti-Discrimination legislation. However, two member states to date have implemented some elements, this being Suriname and the Bahamas. And currently, Belize is in the process of tabling an anti-discrimination bill, which was guided by the PANCAP Model Anti-Discrimination legislation. I just want to go quickly to make reference to a position paper on the human rights situation in the Caribbean, which was completed in September of 2018. The position paper indicated that 4 countries to date have specific legislation regarding willful transmission of HIV. The first being Belize. In Belize, section 46.01 and 73.02 of the Criminal Code, Chapter 101 of the revised edition of Laws 2000 states this. In Bahamas, Section 2, Section 8, Clause 2 of the Sexual Offences Act also states this, and in St. Lucia, it will be Section 140 of the Criminal Code also states this. In the case of St. Vincent and the Grenadines, it falls under Section 291 of the Criminal Code, Part 1 to 4. Even though Jamaica does not criminalize the willful transmission of HIV, just recently, the Joint Select Committee in Jamaica was appointed to complete the review of the Sexual Offences Act, the Offences Against the Person Act, the Domestic Violence Act, and the Child Care and Protection Act. The Joint Select Committee in this case in Jamaica made a recommendation for the amendment to the Offences Against the Persons Act to make it a criminal offense for an individual to willfully or recklessly infect a partner with any sexual transmissible disease that can inflict serious bodily harm to that partner. This recommendation for legislative amendment is currently being considered in the House of Parliament. I just felt the need to include those vital comments. We will now take questions, and I will go ahead and read the questions out. So the first will be, will these PowerPoint be provided via email?
Yes, sure, we can provide the PowerPoint presentations. So all the persons who have registered, and if there are other persons who are interested, we'll certainly be able to send the PowerPoint to them.
Okay. The second question, the speakers have not referenced the findings of the Global Commission and the law as it relates to criminalization. Is this still a useful reference document in this regard?
My answer is yes.
Yeah.
There is a comment. The responsibility and consent of the partners at risk of contracting HIV when having intercourse with PLHIV, even in the absence of HIV status disclosure, should be given due to consideration in deciding who bears the majority of the responsibility towards preventing HIV transmission, and in the instance that exposure or an infection occurs. So it's a comment. Okay,
but
so
a lot of these things are guided by the new evidence that has emerged. In fact, in 2018, you have a consensus statement that was done by a number of global experts. That is available, and we would be able also to send that to the persons who have an interest in it. That goes into more detail, some of the things that we couldn't, in the short time that we had, we couldn't put on the slides.
So I have a question for Dr. Anthony. It will be, among the 68 countries that have laws that specifically criminalizes the willful transmission of HIV, is there any scientific data supporting the claim that criminal prosecution has any appreciable effect in encouraging disclosure to sexual partners by people living with HIV or deterring conduct that poses a risk of transmission?
I think that's a very important question, because people feel that if you put laws in place that you would deter that behavior. But really, over the last 30 years, we have found the evidence to the contrary, that these laws, they actually undermine the public health program. And one of the things that they consider when trying to figure out whether people are intentionally infecting people, they wanted to use persons knowing their status. You would know that we are trying to get the 90-90-90 by 2020. And one of the parameters is really to get more people tested. In just using that one alone, if you have laws that criminalize people knowing their status, then a lot of people would not come forward to know to be tested. And many of the studies have shown that. In addition to that, studies have also shown that persons are not likely to disclose to health professionals their status because they were afraid that that can be used against them. So all the evidence have really pointed to these laws really being harmful to the public health effort in the various countries.
Thank you very much, Dr. Anthony. Another question to the presenters. What are some of the harmful effects a specific law that criminalizes the willful transmission of HIV would have on people living with HIV, key populations, and girls and women? Dr. Ramsammy, I'm not sure if you want to.
Let me just say that the studies that have been done over the last 20 years, or particularly in the last decade, have shown entrenched patterns of disadvantages. For example, in many of our jurisdictions, women are at a disadvantage, and they sometimes face the choice: do I reveal my status, because they can then face violence and discrimination, etc. So that, and then we have the studies that show that persons living with HIV in jurisdictions where HIV is criminalized go underground. They do not seek out testing. They do not seek out treatment, and this not only lead to disadvantages to that population, but keep risk high in those communities. And there are other patterns of disadvantages in these jurisdictions, but I don't think time allows us to go through all of them.
Thank you very much, Dr. Ramsammy. And the final question, this is to Dr. Anthony. Given the contrast in recommendations when we look at Guyana and Jamaica, what would you recommend as it relates to the approach moving forward for Jamaica?
Well, I think it's ultimately up to the Jamaicans to decide what's the process. But what we can help them with is to share experiences and technical documents that shows that when you put in these types of laws, what is the effect? And I think all of us would like to see that we have a better public health response. And we all want to work towards ending AIDS by 2030. And therefore, we want to share experiences that can allow parliamentarians to play that role and to make sure that we are able to end AIDS by 2030. So, like the Guyana experience, I think that would be very informative to colleagues in Jamaica. They can look at the process that Dr. Ramsammy would have described and perhaps see whether it's appropriate for them to adopt and use it as a teaching moment in their society. But you know, every country would have its own unique processes. We can only provide you know, guidance and technical assistance. It's really up to them to embrace it.
Thank you very much, Dr. Anthony. This brings us to the end of our webinar. On behalf of the Director of PANCAP, Mr. Derek Springer, and the participants, let me thank our presenters, Dr. Frank Anthony and Dr. Lesley Ramsammy. Thank you for the two comprehensive and very insightful presentations. Let me also thank you, the participants, for joining us. As a reminder, the webinar was recorded and will be posted on the PANCAP website. This will be shared with the other parliamentarians and PANCAP partnership. Please do join us for the next webinar. The announcement will follow shortly as we continue to share knowledge on legislative issues impacting the enabling environment in the HIV response. Also, please stay engaged with the regional HIV response. Follow us on our social media platforms, Facebook and Twitter. Thank you again, everyone, and see you at the next webinar.